This is negotiation, the art of possibilities. That slide will make a little bit more sense as I continue my talk. I'm putting up my email address, and the reason I'm putting up my email address is, as a speaker, talks develop for me. I've tried to do this differently and talks die, and I'm unwilling to do it the other way because they literally die and they have no energy on the day that I'm giving the talk. So this talk has evolved since the one you have in front of you. If the slides seem important to you, email me and I will email back to you the presentation. Don't have to, but I'm willing to do that. That's a first draft. I apologize for any spelling, grammatical, or any other mistakes in that draft. And literally what I've said is I've tried to change this and it doesn't work. I'm going to start today. Oh, I'm Dr. Paul Wenner. Sorry about that. Work for the St. Cloud Hospital. I'm a faculty member of the University of Minnesota St. Cloud Hospital Family Practice Residency. And I direct the behavioral medicine part of that. So I'm teaching communication skills. And if somebody asks me, what do I do and what's the most important thing I do, I would say to them it's the doctor-patient relationship. I think the rest of the stuff, diagnosis and all the rest of that stuff, is pretty easy. I'm fascinated by human behavior. Always have been, probably always will be. And so that's how also I got interested in negotiations and negotiation styles. I'm going to start you with a video. And it's interesting because I never know whether I should show this at the beginning or in the middle. So I'm going to start, and you can decide if this is how I'm going to teach negotiation skills or not. This is Bob Newhart. Enjoy.
Dr. Switzer?
Yes, come in. I'm just washing my hands.
I'm Catherine Bigman. Janet Carlisle referred me.
Oh, yes. Fear of being buried alive in a box.
Yes, that's me. Should I lay down?
Oh, no, we don't do that anymore. Just have a seat. And let me tell you a bit about our billing. I charge $5 for the first 5 minutes. And then absolutely nothing after that. How does that sound?
That sounds great. Too good to be true, as a matter of fact.
Well, I can almost guarantee you that our session won't last the full 5 minutes. Now, we don't do any insurance billing, so you would either have to pay in cash or by check.
Wow. Okay.
And I don't make change.
All right.
And go.
Go.
Well, tell
What?
me about the problem that you wish to address.
Oh, okay. Well, I have this fear of being buried alive in a box. I start thinking about being buried alive and I begin to panic.
Has anyone ever tried to bury you alive in a box?
No, but truly thinking about it does make my life horrible. I mean, I can't go through tunnels or be in an elevator or in a house, anything boxy.
So what you're saying is you're claustrophobic.
Yes, that's it.
All right, well, let's go, Catherine. I'm going to say 2 words to you right now. I want you to listen to them very, very carefully. Then I want you to take them out of the office with you and incorporate them into your life.
Well, shall I write them down?
Well, if it makes you comfortable, it's just 2 words. We find most people can remember them.
Okay.
You ready?
Yes.
Okay, here they are. Stop it!
I'm sorry?
Stop it!
Stop it?
Yes, S-T-O-P, new word, I-T.
So, what are you saying?
You know, it's funny. I say 2 simple words, and I cannot tell you the amount of people who say exactly the same thing you're saying. I mean, this is not Yiddish, Catherine. This is English. Stop it.
So I should just stop it.
There you go. I mean, you don't want to go through life being scared of being buried alive in a box, do you? I mean, that sounds frightening.
It is.
Then stop it.
I can't. I mean, it's been with me since childhood.
No, we don't go there. Just stop it.
So I should just stop being afraid of being buried alive in a box.
You got it. Good girl. Well, it's only been 3 minutes, so that will be $3.
Actually, I only have a 5, so
Well, I don't make change.
then I guess I'll take the full 5 minutes.
Fine. All right. Well, what other problems would you like to address?
I'm bulimic. I stick my fingers down my throat.
Stop it! What are you, nut of some kind? Don't do that.
But I'm compelled to. My mom used to call me fatty.
No, we don't go there.
But I've been having this dream.
No, we don't go there either.
But my horoscope did say...
We definitely don't go there. Just stop it. What else?
Well, I have self-destructive relationships with men.
Stop it! You want to be with a man, don't you?
Yes.
Well, then stop it. Don't be such a big baby.
I wash my hands a lot.
That's all right.
It is?
I wash my hands all the time. There's a lot of germs out there. Yeah, don't worry about that one.
I'm afraid to drive.
Well, stop it! How are you going to get around? Get in the car and drive, you kook. Stop it!
You stop it! You stop it!
What's the problem, Kathy?
I don't like this. I don't like this therapy at all. You're just telling me to stop it.
And you don't like that?
No, I don't.
So you think we're moving too fast? Is that it?
Yes. Yes, I do.
All right, then let me give you 10 words that I think will clear everything up for you. You want to get a pad and a pencil for this one?
All right.
Are you ready? Mm-hmm. All right, here are the 10 words. Stop it or I'll bury you alive in a box!
You can decide if that's the negotiation style I'm going to teach. Okay. So I want to start with a quote from Dr. Kelly Wilson, who comes from one of the teachers in ACT, Acceptance and Commitment Therapy, which is a fascinating therapy if you're interested. Fits well with the medical model. And what Kelly says is, I'm not interested in probabilities as much as I'm interested in possibilities. I care less about what is likely to happen and more about what could happen. This may appear naive. In a certain sense it is, but it is not a naivete born of ignoring or denying what is likely. It's a naivete chosen, a sense of wonder chosen in the service of those who ask for my help. At the core of every negotiation style, I'm going to expose you to 5 of them today. I couldn't train you in any of them in an hour, so what I just decided to do is whet your appetite, see if one takes, see if you want to go do some more reading. I give you the resources. You can go and examine it. I'll give examples. Everything will be around case studies. At the core of it is thinking about possibilities. Now, if a person's coming down, this comes out of telling people I'm going to give this talk, and they all would turn to me repeatedly and say, oh, you're talking about possibilities when somebody's pointing a gun at you. Okay? If somebody's coming down the hallway pointing a gun at you, you need to do something. Okay? That you'll learn later on as a BATNA, best alternative to no agreement. You need to do something. You need to call emergency. You need to 911. You need to do something. But there's a lot of things that went on before the man entered the hospital. Most of our lives are not around active shooters. I do bring up an instance with a gun that happened with me, but most of our work is not about a shooter. But we can do things that either escalate or de-escalate the emotions that we have between ourselves and who we're working with. And that's thinking about possibilities. And the way Kelly Wilson went on to explain this is before we go there, I had to quote my daughter. This is my middle daughter who's a biochemist at 3M. When I told this to her, she said, "Oh, Dad, that's experiment stuff." When you're trying for possibilities, you're trying to understand motive and the person, but being the statistician, what she told me was, when you're trying for probabilities, you're trying to understand the actions and only react to the actions. So it misses the person. And you'll hear me again and again and again talk about having to be curious about who you're talking with. It's the core of this whole possibility. So Kelly Wilson said, yeah, it's naive, but let me talk about possibilities. So he brought up an old argument, Pascal's wager, in terms of God. So Pascal said, God exists or God doesn't exist. Okay? So I can live as if God exists. And if God exists and I live that way, I have infinite gain. Great stuff. If God doesn't exist and I live as if God exists, no difference. No difference. If God exists and I live as if God doesn't exist, there's loss of infinite gain. Huge loss. And if I live as if God doesn't exist and God doesn't exist, then there's no difference. We go on. So what happens if we apply this wager to people we're talking to? And this I call Wilson's wager. So in Wilson's wager, you can either act as if something extraordinary could happen, or you could act as if something extraordinary could not happen. If you assume yes, that something extraordinary happens, and something extraordinary does happen, you and your patient get to experience success. And it's the kind of success, I don't know if you've ever been with somebody who people have said will never be a success, and they proved it wrong, and they're successful. I have been an elementary school teacher. It's quite incredible when you take somebody who's been taught as they're dumb and teach them that they know. The classic experiment is from Boston, 5th grade. They brought kids in at the beginning of the school year and they said, you know, we tested these kids and they are extraordinary. You are so lucky as a teacher to have this class. And those kids exceeded far beyond what anybody expected, even in a brilliant class. Those are ordinary students. NPR just had a program on this last week talking about that, our expectations of how we treat people and how we, in terms of their efficacy, their ability to function. When we treat people that way, something extraordinary can happen. If we treat them as if nothing can happen, and I assume yes, that something extraordinary, and it all falls apart, which happens, I'll feel bad, and maybe your patient feels bad, but often in those cases the patient doesn't feel bad because they don't recognize what just happened. If I assume, if something extraordinary happened and I assume no, I've then sold my patient short. So anybody I interact with, if I treat them as if we cannot change and negotiate, I've sold both of us short, actually. I've sold out my ability to negotiate well, and I've sold out the patient's ability to change and to function. If I assume no, something extraordinary could not happen, you feel good about being right about what a useless case your patient is. How often that happens. Self-fulfilled prophecy. Resident, hospital rounds, Tuesday morning. Walking around, before we walk into the room, I say to the residents, what do you want to accomplish? The resident says to me, they're going to fight me about wanting opiates, narcotics. I said, difficult patients, typically happening these days. I said, what else could we do? And you're going to see, we talked about motivation interviewing, and I'm going to give you some thoughts about that. So we walk into the room, and the patient is happy. Doesn't argue at all. Agrees with the treatment plan. And before we could get out of the room, the resident started a fight with the patient. It was unbelievable. I mean, I just started to laugh as we were walking out of the room, and the residents looked at me, what's so funny? And I said, You know, that was going great until you got in an argument with the patient. But if somebody wasn't there observing, or if the resident wasn't self-aware, that would have been a patient who was difficult to deal with. As opposed to, there's always a possibility, no matter what you walk into, that something will turn out well. So, I'm going to bring up 2 examples in my life that happened to me. Parents bring in their 18-month-old for an 18-month exam. I'm a PA at this point in training and had not met the family previously. I come into the room and I sat down and asked what they wanted. The father pulls out a gun and sets it on the table and said, "My daughter and wife have not been getting good care. They're going to get it today." I'm going to hold your attention. I'll let you know what happened there at the end of the talk. Second case happened 3 weeks ago. I'm talking with a colleague, and the head nurse comes by and interrupts us. Unusual behavior in our clinic. And says they're having difficulty with a patient down the hall. We walk down the hall, and as we turn the corner, I could hear the patient yelling and screaming in the room. There's a crowd that's been gathered outside of the room. We'll talk more about that at the end of the talk. There are 5 theories that inform this presentation that I want to talk to you about. Emotional intelligence, Getting to Yes, which is a book, Difficult Conversations, which is the book, Motivational interviewing, and Learn. First case we're going to deal with it from the perspective of emotional intelligence. A resident physician rushes into the patient's room, and the patient has already ripped out his IV, packed his knapsack, and is making his way for the door. His hospital gown was on backwards, flapping like a cape over his jeans. He said he felt fine now after coming in feverish and sweating a few nights back. And despite his poorly controlled HIV and the strong possibility that the lump in his neck is a lipoma. We have waited several days for results, and he had had enough. Just then the attending physician, which means the faculty physician, arrived and calmly approached the patient and offered him a glass of water. So what does that mean in terms of emotional intelligence? And I'll talk about what happened in the end. In emotional intelligence, and this comes from a book called Primal Leadership. And let me just go back just a little bit. Emotional intelligence comes out of the 50s. In World War II, the Army decided that the person with the highest IQ was going to be the leader of the forces. How well do you think that worked out as a leader? IQ, good predictor, bad predictor? People are shaking their head. Bad predictor. But they didn't have any other predictors. So they asked Goldman at Harvard to figure out what makes a good leader. Because they knew at this point that intelligence may be a part of it, but wasn't the whole story. So Goldman took he had people select across the country outstanding leaders and studied them and came up with the concept of emotional intelligence, another kind of intelligence. In emotional intelligence, there are 6 leadership styles. The resonant ones, which means they add energy to the interaction. So you can use them all the time, you can use them freely. They're visionary, coaching, affiliative, and democratic. The dissident styles are pace setting and command and control. The visionary is pretty obvious. You're talking about the future, you're talking about possibilities, you're talking about what could happen. The coaching is about seeing what the person's doing and teaching them about something that they may be able to do different. It's a very complicated skill. When you watch it done well, it's just absolutely amazing. I'm into basketball and women's basketball. Cheryl Reeves of the Lynx does things as a coach, and people just are in awe of her. She can get that team to perform as a group. There's something she's doing that's coaching that says this is how you do that in terms of her style. And there's other great coaches. Same team, different person, team falls apart. Affiliative means you're establishing relationship with the patient. Democratic means you're going to vote on it. Pace setting means that you always lead. You always have the right way. If somebody else does it, but it's not your way, you're going to go behind them and do it in a way that you know is, unquote, quote, right. My mother's kitchen, her way or the highway. But that's a whole other discussion. We won't go there. Just say no. or stop it. Commanding is, command and control is you take charge. ER code, somebody has to be command and control. So none of these styles are bad. If you use two of them, which are the distance styles, eventually you're going to draw out all of the energy out of the group, and the group won't be able to function well. Which are the two, and I know this in terms of teaching physicians, which are the two styles, I'm already telling you, do you think they teach in med school? Mark's laughing back there. Pace setting and command and control. And now we're taking physicians and telling them, you have to be part of a team. Well, the difference between those two are huge. It's interesting, when new residents come in, the resident we absolutely love is the pace setter. We absolutely love them. At the end of 3 years, we're going to hate them. I mean, you don't hate them, but we're struggling. We're struggling. Because they always have to have it done their way, in this one particular way. There's no flexibility. They do all kinds of work. They get it done. They're obsessive compulsive. They always have to lead. They get in fights with their... It's a huge in terms of difference. But both are important. But you have to have the standard ones up above in terms of being able to lead well. Change theory says, in terms of research, there are 4 factors that contribute to your changing. Number 1 is the technique that who you're working with is using. Number 2 is how you think about things. This is from a patient standpoint. Number 3 is the relationship you're in with who's ever helping you. And number 4 is placebo. 40% is done because of how the patient thinks about things. What did the attending physician do? He pulled out a napkin and explained what was going on so the patient could understand what his concerns were. 30% is affiliative. He offered a glass of water. He smiled. I'll talk about it a little bit later on. He saw the patient as a sunset to be enjoyed, not a math problem to be solved. One of our problems in medicine is we're solving problems, so we see patients as problems, not to be enjoyed. Escalating, higher emotions, disconnect emotionally. So we're now at 70% chance of change. The third one is technique. This doctor used good technique style. So we're now at 85%, and 15% is placebo. So we've greatly increased the chance of change because of the leadership style we've used in negotiating with this patient. So what happened? The attending understood the patient's frustrations, apologized for the delay, and promised to call the doctors in the pathology department to see why the test results were taking so long. He asked where the patient was planning to go, why he felt it was so important to leave. He grabbed a napkin and drew a quick sketch explaining how this disease would likely progress and the many risks of leaving without treatment. The patient's response, all right, doc, I'll give you a couple more days. It's a true story, came out of the New York Times. So that's emotional intelligence. Great stuff, self-aware, what leadership style you're using as you go into negotiations. Second case, 54-year-old man presents the ETC with crushing chest pain and is found to have a ST elevation, myocardial infarction, heart attack. The patient needs a heart catheterization with a likely stent placement, but he insists on leaving the ECT. The physician is unable to convince him otherwise, despite confirming that he understands the risks and consequences of his decision. He leaves and returns via ambulance 7 hours later with a cardiac arrest. What happened and what could be negotiated difference? So we're going to move to a second style of negotiations, or theory, called getting to yes. This is the Harvard negotiation team. It's used in international negotiations. It's used between unions and business. It's used multiple places. They have a Center for Negotiation at Harvard. It's a really thin book that seems so simple. As my kids said when I gave it to them, they said, duh, because it makes sense. So one of the bases to whet your appetite in this is that they talk about 2 types of typical negotiations in this culture. The hard negotiator and the soft negotiator. The hard negotiator has a goal, is the pace setter, something they want to get to. This is what they're going to get to. Nothing stands in the way. This is going to be the outcome. People usually stop liking working with them. People are usually frustrated. A lot of things go on. But things get done their way. Not as a group, but their way. The soft negotiator is always worried about the person they're negotiating with and always worried about the relationship with the person they're negotiating with. Well, if you can imagine, in that negotiation, agreements are really sloppy. Really sloppy. People can't understand because they're shifting all the time because of that concern in terms of the interpersonal concern. And so it's hard to get things done. It's just confusing. You need to know, you can say I don't have one and I'll disagree. You need to know what your style is when you get caught in a tight spot, because it's where you're going to go. And either you're going to end up being the hard negotiator or soft negotiator. You can modify that, and I'll talk about that in a second. But it's important to know what your first, when words come out of my mouth, my first negotiation style just comes out of my mouth. It's there. It's how I do things. It's very useful in some ways and harmful in others. So, in their theory, you need to be a principled negotiation, which means you have to know the other person's interest. You have to be curious about the person you're negotiating with. You can use something called, when you're trying to advocate for your stand and inquiring about the patient's stand. So it's called advocacy and inquiry. You can Google that and you'll learn lots of things in terms of statements. But you may say, this is how I think about this. This is what makes, tell me more about what makes sense to you. Or you may say, gee, I don't understand. This is how I got to me. Help me about how you got to the understanding. What's going on? What's behind that? Real curiosity about what the other person's thinking and what's going on. That's the principle of negotiations. Once again, it centers on interests. It's not win-win, which are two hard negotiators both giving up a little. This is about, oftentimes, if you know interests, both sides can be met. And this interesting thing called a BATNA, best alternative to no agreement. Best alternative to no agreement is that if you can't get to an agreement, you have to know of which you're unwilling to meet the other person's interests. If I'm selling a house for $230,000, if my BATNA is $130,000, I offered for $200,000. So let's say $230,000 is what my BATNA is. I'm selling on the market for $270,000 and somebody offers me $220,000. I don't sell it because it's below my BATNA. So whenever you're in a negotiation, in terms of principal negotiations where you're talking about interest in negotiating, you have to have a BATNA. You do not present your BATNA as a way to start negotiations. That's something you hold to yourself. It is not a line drawn in the sand. That's called hard negotiating. But you have to know where you're unwilling to go below and you're unwilling to walk away and live with the consequences of having no agreement. So what happened here is it turns out the patient had a dog at home. He didn't want to leave the dog alone, so he went home. That's why he didn't take the advice out of the ETC. Somebody had to say to him, you know, we see you as really sick and you have a chance of dying. Tell me, it makes no sense to me. Tell me about why you want to get home so bad. So less about the education and more about curiosity in terms of the patient, in terms of what's going on. A patient presents in the outpatient clinic. When he's seen and examined by the physician who asks what brings him in, he says, I have only one more day of medications and need refills. The physician says those are not medication he prescribes and he will not refill the medication. The patient starts to yell and wants to see the head of the clinic. The physician leaves the room. Tension, things aren't going well. I want to put this in the context of, this is another book from the Harvard team called Difficult Conversations. There are conversations that each of us in the room do not want to have with certain people. We just don't want to have them. It might be your teenager, might be your wife, husband, partner, might be your boss, might be a coworker. You don't have to have them, but then nothing changes. So if you're going to have them, the first thing you have to do is figure out, why is this going to be a difficult conversation? Why was it difficult for the physician to say something besides just, I don't prescribe those meds, and get in a fight with the patient? And why was it difficult for the patient in terms of yelling, starting to yell and scream when what he's asked for is medication and isn't going to get them? There are three things in this theory that make something a difficult conversation. The first is arguing about what happened. What, when, where, who. What are the facts? Just the facts, ma'am. And when you get in that argument, I've raised 3 kids, have some grandkids. When you get in an argument about what happened, what, where, when, who, You never quite find out where happened. And it's also true, I've been a marriage therapist for 40 years, and that discussion in marriage therapy is absolutely useless. You need to change it quickly because it ain't going anyplace. Both are absolutely sure that this is what happened. And I know as a psychologist, neither one have it right. So it's some third thing that went on that I will never get to anyway. So the what happened is not, it makes difficult conversations, doesn't get anywhere. Emotional. There are things that affect us emotionally. I don't care who you are, male, female, CEO, police officer. There are things that you can hide them, but they affect you emotionally, which means they will affect your behavior. You have to know that. And in most of the time, so if I'm dealing with patients, of somebody I'm trying to help or somebody in the hospital patient, I'm going to acknowledge the emotion because I don't want it coming out sideways. This makes me angry. This makes me sad. If I think I'm going to cry, this may make me cry, even though I don't cry, but if I'm going to. Now, would I use that negotiation with somebody holding a gun to me? No, that's not the question here. This is a different set of questions. This is before that. But once you are vulnerable enough and secure enough in who you are to name the emotion, you then change the conversation to up here, which is data, to emotions. And as a psychologist, I will bet the bank account on emotions over data. If I want to watch a person's behavior, it's what their emotions are, not what the data is. I do a thing called decision balance. And I have them give emotional and rational reasons and have a way of asking that, why they may stop smoking and why they'll continue smoking. I just add up which are the strongest emotional reasons, the most emotional reasons, and that's what they're going to do, even though they may say something else. That's how our brain works, folks. Willpower works for a while, but it's emotions. And the third one is identity, and this is the one that really gets hooked in people. And what it is it's a challenge often to your competency. It's a challenge that I may be incompetent. I mean, my worry of giving this presentation is I may be incompetent as a psychologist and a presenter. Great fear of mine. It causes stuff in me. It's difficult conversation. It can be difficult if the person is challenging my competency. When you don't know what you're doing, or act something like that. All of those are difficult conversations and I may avoid them. If I'm in negotiations, I have to know that that's what it's triggering in me, because then I can take care of it and deal with it. So what happened? So this patient leaves the room, goes out in the lobby and starts yelling at the front desk. They come and get me, so I go out. They think I'm a psychologist, so I should be able to deal with it. It's a whole other discussion. So I go out into the lobby and ask if the patient and I can talk. We go back into a room and the patient states that he is scared. He has kept sobriety for 4 weeks and had a decent night's sleep for the first time in months. He's able to name that he was directed to our clinic to have his meds refilled. I acknowledge that, and at this point his voice lowered and we're able to discuss his interests. What do you need today? What are behaviors that may get you that? I don't think the behaviors you're exhibiting are going to get you that, because what's going to happen is you're going to get thrown out. And I'm going to call security and you're going to be leaving. And I can name the clinic's interests and how those could be met. So it's really examining interests. It's emotional because this patient thought he was going to have to go out without any medications. And he was scared. He was fearful of not having a decent night's sleep. He was fearful about losing his sobriety that he's held for the first time in 10 years for the last 4 weeks. I haven't been able to talk to the physician, but if I could figure out a way to ask the question, one of the things I'd ask is, does a patient coming to you and asking you for meds that you can't prescribe, does that in any way challenge your competency? You don't ask a pace setter such a question. But it may be one of the things, and I don't know if that's true. It may be that medically, whatever. And it was appropriate. I mean, a number of physicians don't prescribe those meds, so it's appropriate. But it all matters how you apply it and how you do it in terms of doing that. A 24-year-old male patient tells his nurse he's going to leave. He doesn't want to be in the hospital and he's going home. His physician has ordered more tests which have not been completed. He's gotten his clothes on. His verbal abuse increases towards the nurse. Let's put this in the context of motivational interviewing, which is the most evidence-based research way to interview within the medical setting. If Rolnick and Miller were here today, These are the people who've come up with this system. They would spend the first number of hours not discussing technique. They would talk about the spirit of motivational interviewing. Because the techniques will not work unless you believe that all patients, particularly the one you're dealing with, is ambivalent about their unhealthy behavior. It's a hard thing to do. It's the same hard thing of thinking of possibilities rather than probabilities. But it's curious. It's looking at the patient or the person you're dealing with as possibilities that they can really change. So you have to hold that. And the techniques will not work if you do not hold that. Second one, in motivation interviewing, you never push against resistance. Once you've pushed against resistance in an interview, what happens when somebody pushes against you physically? You push back. All you've done is increase the patient's resistance. And they've resisted the smoker, the drinker, the drug user. They've resisted pushes for a long time. And they're going to push, and they're pretty solid, well defended, know how to push back, know how to put the ball in your court so it becomes your problem, not their problem. So it's huge in terms of how to do that and not pushing against it. So I'm going to teach you or explain to you 4 ways of dealing with resistance from the view of motivational interviewing. These are really simple, and I'm smiling because I do something called batting practice. I have the residents, or when I've taught this to physicians, I make them form 2 lines. And one line's the pitcher, and they will pitch resistance statements at the resident standing over here in the batter's box. And the batter has to respond back to the pitcher and the statement. It's really hard to do. It's like tongue-tied because you know what you want to say, but it just doesn't come out because you want to push against resistance. You want to tell them what they need to do. So let me give you some of them. The more you practice them, the easier it is. The first one is a simple reflection. Reflecting back what you've either heard in terms of word or what you've heard in terms of emotions. Client, I wish I could be more like my sister. Interviewer, you'd like to be like her. Simple. All you're doing is joining the client. You're not teaching them anything. And you do that in motivational interviewing until the patient gives you a cue, this will be the same in negotiations, that they want to change. They give you a cue that they're open to interest of having something accomplished today, not just fighting. You then switch to what promotes in terms of the change talk. But this is resistance talk. It's the first step. Amplified reflection. These are dangerous for me. I can get sarcastic really, really quick. I do not use amplified reflections because every time I do them in practice, they come out as sarcastic. I don't know. So an amplified reflection. Client, I'm frustrated with my wife. Interviewer, you're angry with her. It just ups it another notch. It just turns up the heat a little bit. Once again, trying to get the patient to own what the problem is or how they're feeling or self-reflective of where they're at, not telling them what they need to do. The third one is my favorite. It's called a double-sided reflection. Client, I'm just so confused. I love my kids, I really do. And I think they are the most important thing. But I keep making choices that hurt them. No matter what I do, I end up doing dumb things. Interviewer, you care for your family and yet you keep hurting them. Now I want you to be aware of some words here. The interviewer did not say, you care for your family, but you keep hurting them, which is the typical way of making the statement. They used the word and. What the word and does is it holds a conflict. You're holding 2 things. It's not one or the other. Both are true. And in this statement, both are true. I love my family and I cause them harm. In psychology, we call that cognitive dissonance. Now, if you've ever been in therapy, a therapist may have done this to you. They may have given you a conflict that both are true in your life and left you with it that you have to resolve it. Because the trick of this is then to shut up. Not tell them how they can resolve the conflict, because they have to resolve the conflict. And for the next week, every time you want to use a but, use an and see what happens. See how it radically changes the things you talk about. So, once again, you're causing cognitive dissonance, you're saying both. They want both. Reframing, which most of us know, and I love this reframe. Client, I can really hold my liquor. I can drink most guys under the table and not feel a thing. Interviewer, your body has lost the ability to tell you something is wrong. It's a great reframe. It's a great, and if you're cooking on all cylinders, you go, wow. Once again, it leaves it with the client. You're not solving the problem. Often in negotiations and things, we think, no, I'll own it myself, I think I have to solve the problem, as opposed together that we can create something that's going to be resolved. And these techniques are really about together in terms of people owning where their problems are. Any questions about those simple reflections? They're pretty straightforward. Okay. How many people have been trained in motivational interviewing? Any in this group? 1, 2, 3. Okay. Great training. Motivational interviewing website is a great website. Very open with their materials. They're not one of these societies that hide the materials. They give it out freely. You can get their materials, all of it. Great stuff. So, what does the nurse do with this patient who's going to leave? The nurse does a reflection. Says, he seems angry. The patient comes back with what typically when you sometimes do a reflection, sometimes they say, I don't want you doing that to a psychologist because how do you feel is such a comical way of psychologists and how we deal with things. But the patient says, duh. The nurse doesn't take up the duh, doesn't push against resistance, but the nurse asks what he thinks needs to be done. He's worried his girlfriend will leave if he stays in the hospital. The nurse asks on a scale of 1 to 10, 1 being that she will leave, 10 being that she won't leave. What are the chances she will leave? He pauses and says a 6. And the nurse asks, why didn't he say 8? Now, why did she say 8 and not 3? Why when you say on a scale of 1 to 10 to a patient, what are your chances of quitting smoking? 1 to 10. 1, you won't quit. No, I'm sorry. 1, you will quit. 10. It's the second time I've done this presentation. I'm losing abilities. At my age, that happens. Okay. At 1, you won't quit. At 10, you will quit. And the patient says 8. And you'll say, well, why didn't you give me a 3? Which means I want to know the strengths. Why didn't he go lower? What does he think can give him an 8 that he will quit? You want to know their strengths. When I went through my training, we would say the higher number thinking we were motivating them and teaching them motivational skills to make the change. Doesn't work, folks. Need to get the patient to see their strengths, their abilities. This allows the patient. So give me a 3. Give me an 8. What keeps you? Oh, my girlfriend loves me. She cooks dinner for me. Whatever it is, now I've hooked him. Now it's his. And now we can get on in terms of keeping him there, in terms of what the chances are. Because chances are he will stay. A 24-year-old Somali woman comes into the hospital to deliver her baby. Because of multiple medical problems, it is decided she needs to have a cesarean section. The woman and her mother say no. This is the learn model, negotiating across in terms of cultural competency. The Department of Health for the state of Minnesota has noted the most important thing in terms of health in Minnesota that's getting in the way is racism. which is really about, it talks about structural racism, but it's really about being able to make the divide across races and how do you negotiate that. This, to me, is one of the more difficult negotiations, because I may hear things that are absolutely diametrically opposed to everything I believe in, and they are absolutely sure that that's how the world is and how the world has to function. That's how they were raised. It's their culture, and I have my culture. And the question is, how do you do that in central Minnesota? So one of the things that they're using, and if you Google Learn, you'll see a doctor using this down. I think it's Health Partners. But she uses the Learn method. So the first thing in the Learn method is you listen. You're starting to get the theme of this. You have to know where the person is you're negotiating with. Critical first step. Okay? Listen with empathy. Empathy means I stand in their shoes and understanding to the patient's perspective. Now, empathy is exceedingly important, but the ability to come out of empathy and stand back and own who you are is equally important. So after you empathize, you come back and you explain, in our medical system, not the way it's done medically, which is a typical way this is explained, but in our medical system, this is what we think is the best care. This is why we think it's the best care. The patient will come back and say, well, you know, this and this and this happens, and it's really important to acknowledge their feedback and then recommend a plan that possibly try to fit both things. This is difficult, cesarean, no cesarean, it's difficult to get interest, and negotiate a course of action. In the hospital, a number of years ago, this would have been a court case. The only way a cesarean is going to get done is if we bring judges in. It's a terrible time. It's had to be done. Mother's going to die or the baby's going to die. Get a judge involved, get a court case, and take a delivering mom into the ER, into the surgery to deliver this baby. There are other ways to do this. So in the wisdom of the hospital, they brought in somebody with cultural competency. And she discovered that in Somalia, if you have a cesarean section, you're sterilized. You will not have another baby. That's it. It's done. And in Somalia, as close as I can understand it, is that as a woman, your integrity, your competency as a person is having babies. So you're asking her to not have a baby and not be able to have any more babies. Well, a number of negotiations had to go on. The elders from the community had to come in. We had to explain that. In the wisdom, the OB department has a Somali community health worker who has made an incredible difference because she lives in both cultures, which has been an incredible difference, so she can understand Somali and she can understand ours and can negotiate that for us. She talks Somali, which is, I don't know how many of you have used interpreters. It's radically different if somebody's using their own language. I always tell people that object, I always say, you know, if this afternoon you drop me in Vietnam and I break my leg, what's that going to be like for me? I won't understand anything. Anything. It's not like it's kind of German, which I could pick up a few words, or Spanish I can pick. Nothing. I mean, it's not going to make any sense to me. So you have to negotiate, you have to do an understanding. The trick that the hospital learned about negotiations is this negotiation is done before the person's in crisis sitting in the hospital. Who's involved, what's involved, getting the elders in their religious community to say, yes, it makes sense to have a cesarean. This is the reason why, because of medical necessity. In Somalia, women died when they didn't have cesareans. All of that negotiation had to go on. But it had to be understood and respected from the point of view that Somalia also has a legitimate culture and has their experiences. Not everything we do is the absolute right way of doing that. Incredibly important how to negotiate, particularly across cultures. And I find it the most difficult negotiations. Across cultures, across race. Because things sometimes just don't make sense. I really have to pause because I always think I hold the truth, and I don't. I just hold an idea. So, what happened to the patient with the gun and the other one yelling and screaming? I'd have to tell you successes, wouldn't I? In terms of the one with the gun, this is 1970. None of the stuff that was talked about in the other room was talked about in any of my training. This just, ERs even in Denver were open, no security guards. The security guards were around, but they certainly weren't around. So I was cooking, my brain was working right that day. I looked at him and said, yes, I'm going to, what do we need to do? And we figured out what we needed to do, and I did a full, as thorough of an exam, an 18-month-old exam as you could do in terms of development and everything else, and the child was perfect, thank goodness, because if something had been wrong, it wouldn't have worked out so well. The patient, the father never went for the gun, never threatened me again. It stayed on the table. He moved around. He moved with the child. I then said, gee, I have to go because I precept this community clinic. So I went out and talked to my preceptor, and I said, there's a man in there with a gun. And I just did the 18-month-old exam. You did the yeah, I did the 18-month-old exam. That's what I did. We did two things. One is I walked back into the room with my preceptor, and we explained to the man. First of all, we explained about his daughter's doing fine, these immunizations, all those kinds of things. Then we explained to the man, you can't have a gun in the hospital. We're going to take the gun away. And security was outside, and they took the gun, they left. Nothing happened to the man. It still boggles my mind. Thinking today, man, everything would have been very confusing. The man had just gotten back from Vietnam 3 days before. He came from a culture of being on the front lines to seeing his child who was sick and his wife who was sick, and brought the culture that he had been fighting for those years over in Vietnam, brought him into our clinic, and he was going to get things done. And that's how he approached it. Turned out well. Lucky. Lucky, lucky. All kinds of other things could have happened. All kinds of other things could have happened. And I don't know if I'd do it the same way. One of the things that I picked up, and it's intuitive, is that he wasn't going to threaten me anymore. He could have done some other things, and I think I would have done something else. Or I hope I would have. The next one I didn't do as well with, and I could have caused a lot more problems by how I did this. So I turned the corner. I'm a little old guy, so sometimes I wonder, what are they sending me in there for? But I'm also the one that they think can deal with it, so my competency, and I have a little ego going here in terms of what am I going to do. And I take my glasses off, because anybody who wears glasses know you do not want to be in a fight with glasses on, because it messes up your face and it's just bad stuff. And one of the nurses goes, like this, and backs up, and it's okay, it's okay. And I decide, and this isn't, I don't think it through, so I'll go back and I'll go through it what I think would be different if I had to do this differently. Intuitively, I wanted to talk to the man. Once again, I'm a negotiator. It's where I come from. So I think I'm going to negotiate with him. He's yelling and screaming and just causing problems in the clinic. And I think, the clinic has to go on. So I open the door a half an inch. The guy takes his two hands and rips the door open as I'm standing there. I'm talking to him. I'm trying to talk to him. I catch his eye. Thank goodness he makes eye contact, because if he didn't make eye contact, I'm not sure what would have happened. He and I kept eye contact, and I kept saying, what do you need? I didn't tell him to be quiet. I didn't tell him to slow down. And there's a really interesting, I'm going to deviate just a little. There's some interesting research that when somebody's really accelerated and you want to decelerate them, you match their acceleration, and once you're matched and mirrored, you slowly slow down and they slow down with you. I'm frightened to try that technique. My technique, because I don't know what's going to happen, so I've never gone there. My technique is to become exceedingly calm, exceedingly calm. It's been interesting. I'd always wanted to have a heart monitor on me when I'm in the middle of this, trying to figure out how fast is it going or what's going on. And I keep saying what's happening. And I realized very quickly, this man's much stronger than me at this point. He gives the door another jerk, and I spin around, and now I'm facing backwards, so he's behind me, and I'm facing this crowd of people facing us. And one of the things that happens is one of the case managers, RN nurses, worked as a bartender. She went into drunk mode, which was wonderful. She just said, put her hand up, stop, slow down, slow down. And I'm saying, what's happening, what's happening? He said, I have to get out of this room. You locked me in a room. Now that makes no cognitive sense. That door opens to the inside. Big mistake. But anyway, it opens to the inside. He could have jerked that door open at any time. He didn't jerk the door open. So that would make no sense. I wouldn't think that's what confined him. And the reason we shut the door is that he had already swung at a nurse, which I didn't know about until 15 minutes later. And I have such pain in my legs. Okay. We can get the door open. And he starts to, you see him start to come down, and the nurse and I are getting to him. What else do you need? I need to be out in the hallway. Okay. I can't stand, my legs hurt too much, Okay, get a chair. I tried to grab a chair, they said it's the wrong chair because it's unrolled. They gave me a different chair. Thank goodness I had people helping me. We got him into a chair in the hallway. He sat down, and then he acted as if he went to sleep. I don't know what all that's about, I haven't figured it out. But he wasn't asleep because the nurse said something in the background, and he picked up and said, "You aren't going to do that to me." So obviously he was aware of what was going on in the area. Security came from the hospital, and they were wonderful. We were down talking to him at his level. They got down and joined us in the talk, and the question was, what did he need? He had not slept for 4 days. He had terrible pain in his legs, and he was screaming. And security helped us. What we figured out is we need to get him to the hospital. Security figured out we need to call the police. I'm not taking over in the security car, so they got a hold of the police. The police arrived. The one police officer came and got down on our level. The other puffed up, and I was worried. And he coming into a difficult situation, I get it. In terms of if somebody's going to threaten, you want to be as big as my dog does it, you want to be as big as they are. But he backed up very quickly when he saw that we had it. The man went back in and acted like he was sleeping, and we negotiated with him. He got in the cop car and left the clinic and went over to the hospital. It went well. Did I do some stupid things? Oh, absolutely I did some stupid things. And if I talk to security here, I'm thinking of one, they could tell me a number of things that I may have misjudged. One of the things is I didn't ask anybody what was going on in the room. My ego took over. I have to do it. I'm the person in the clinic who solves these cases. I'm going to take care of it. Not wise. Number two is I won't open one of those doors in anymore because I now know patients can jerk them open. Not good design as far as I'm concerned, but there it is. I also didn't know that he had swung at a nurse. And the fourth one, which was really stupid, is I didn't wait for security because I needed backup if everything went to hell very quickly in that episode, and I had no backup. I was it. The only thing that kept him in the room is I went to my 7th grade basketball stance, so I got lower to him and got my butt into him like I was blocking out for a rebound, which made me stronger than him. It's the only way I kept him in the room for the time we kept him in the room. So all the basketball coaches, even though they think I couldn't play basketball, I can. Oh, I have a couple more minutes, so I want to get to some general principles, and I want to give you one last quote at the end. So these are general principles that I hope you take away, and if you're negotiating or however you're doing this. Be aware of your leadership style. What of the 6 styles are you using today? Focus on interests, not positions. Do not be drawing lines in the sand when you're negotiating. Name interests, naming how things, possibilities. Understand the patient in the context that behavior is their way of dealing with being uncomfortable. This is particularly true of anxious patients who cause all kinds of problems. Know your BATNA. But do not draw a line in the sand at the start of the negotiations. How might we engage with others in a way that yields better outcomes and understanding? And the last one I love, see your patients as a sunset to be enjoyed, not a problem to be solved. Quickly go back to grade school. Who saw you as a problem to be solved? And who enjoyed you? And what kind of difference did they get from you? Think of your coworkers and people over you. Who sees you as enjoyment, enjoying what you do, encouraging you, and who sees you as a problem that they have to change? The people who I did this talk for, they could have gone crazy as I sent more copies to them to be put on the hard drive, and then I came with my own computer today. They could see it as a problem, or they could support me, which meant I could give the talk. So they saw me, and they kind of laughed at me, and we joked. So, my favorite quote for the last couple of years. When we experience the world as too complex, and that today, that talk, having shooters in hospitals, that's too complex for me. It's hard for me to hold that. We're not just experiencing the complexity of the world, we're experiencing a mismatch between the world's complexity and our own at this moment. There are only 2 logical ways to mend the mismatch. Reduce the world's complexity or increase our own. The first isn't going to happen. Thank you. Have a good rest of the day.